Hey guys, welcome to Respiratory 4204, our first micro lecture of the semester and the module. This week we're discussing patient assessment, so I thought it would be a good idea to look at a few different clinical measurement systems that are generally employed in critical illness. We're going to be discussing the SOFA score and the Glasgow Coma score. So over here on the left, right here, we have a very creepy looking picture for our Glasgow Coma scale. Okay. Which I'm sure you've heard it referred to as a GCS, or a patient has a GCS of such and such number to describe a patient's level of consciousness. All right. The Glasgow Coma scale has a range from 3 to 15, with 3 being a vegetative state and 15 being a lucid individual, such as myself right now, I think. And it kind of goes from there. So there's a pretty large range of consciousness or just general being. So uh, Glasgow scores can be broken down into mild impairment, moderate impairment, and severe impairment. Uh, these further are broken down into mild impairment meaning a GCS greater than 13, moderate impairment being a GCS of 9 through 12, and severe impairment being a GCS less than 8. So with this being said, I'm sure people have heard the old term less than 8 intubate. And this is kind of where that comes from. I don't think clinically that really makes a lot of sense. If you look up here to the scale, you can see there's a wide range of levels of response in each of these domains that really can make or break certain situations. So I don't think that's clinically necessarily true, but for an examination such as the ACCS, you'll be led through a scenario where you will have to determine a patient's level of consciousness, and it may or may not fall within this magic 8 number. And in that case, I suggest that you select an answer that leads to an intubation for that patient. Um, the number itself honestly doesn't really mean much, but when you break it down into its parts, it actually tells a better story of the patient. So if you had a patient who wouldn't really open their eyes to anything other than pain, and when they opened their eyes, they would only kind of mumble inappropriate words, and if you did any sort of like pinching or pressure on their nail beds or anything like that, they would withdraw from the pain, but they didn't really have a really appropriate response. You could classify that patient as an eye-opening response of 2, a verbal response of 3, and a motor response, let's say, of 4. Okay? And simply put, this individual's GCS would be 7 plus 2, which is 9, 9. So you can see this is kind of teetering on the edge of moderate to severe. And given the situation, if you have to go and external rub a patient to have them wake up, and they kind of mumble a lot of things, there's a few things to consider. So instead of jumping to conclusions or having this be the end-all be-all, look at this critically. Think about, is the patient on any drugs that we've given them or anything else? Is the patient hard of hearing? Does the patient speak English? And does the patient have any sort of mental illness? These are all things that will affect our interpretation of this GCS score. So please keep that in mind when interpreting this data. And also just remember that reporting it as a sum of its, or parts of the sum, is really much more informational than just reporting a score within itself, as you can see here. All right, so moving on, we're going to discuss the SOFA score. If I can erase this. All right. Just a little less distraction here. Okay, so the reason I discussed the GCS first is because the SOFA score incorporates the GCS, as you can see right here, for its calculation for its endpoint. So what the SOFA score stands for is sequential, organ, failure assessment. And the main purpose of the SOFA scoring framework is to really establish a mortality rate to certain amounts of multi-organ disorders that are found in sepsis and septic shock. Okay, and this definition of sepsis has been redefined throughout the years. In 2016, it was consolidated, and we got rid of the SIRS category. So we're going to stick with these two definitions for now. So, a long story short, a SOFA score can range from 0 to 24. If your score is a 24, then you are in some really, really bad mess right there. So the easiest way to discuss a SOFA score, oh gosh, is to represent the change in mortality rates amongst the scores, okay? So on this side we have mortality percentage, okay? And down here we have the score. All right. So from 100% mortality rate down to 0. So one would think that, wow, we wouldn't have 100% mortality rate, but we get pretty close, you'll see. So down here, we'll have, let's say it's usually defined in these terms. So a score of greater than, a score of less than 9. Let's get rid of this. Okay, so we have a score of less than 9. So a SOFA score of less than 9 generally holds a mortality rate of 33% or less. Okay? A score of 9 to 11 generally holds a mortality rate of 40 to 50%. That's pretty significant, huh? All right, and then we'll extend this a little bit more. It's getting messy. All right. Then a score of greater than 11 has a mortality rate, here we are, of approximately 95%. Okay? So this is based off of the initial assessment. So if someone comes into the emergency department and their SOFA score is less than 9, we would assume that they have less than a 33% chance of mortality or less given their current state. So the thing about the SOFA score is that it's generally assessed every 24 hours to trend organ dysfunction and progression of septic shock. And it's based off of 6 different domains or systems. One being the respiratory system, so we're going to use the PF ratio to qualify what's going on. We're going to look at the liver and bilirubin concentration. We're going to look at the patient's MAP and also any vasoactive drugs they are on, specifically dopamine, epinephrine, and norepi. We're going to look at some coagulation parameters because platelets take a big hit in a lot of these scenarios. There's consumptive coagulopathies. There's like DIC. Platelets also play a huge role in inflammation and developing inflammatory mediators and a lot of fun stuff that we should talk about later in the semester, but we won't today. But generally, when you start losing some platelets, it's really a bad sign here with the SOFA score, as you can see with everything else. We use the GCS to determine changes in level of consciousness. So you can see we start getting to the less than 8 intubate number, as people like to refer to. And then we look at our renal function based on our common endpoints that we look at with kidney activity. We start looking at urine output when we get higher up in the SOFA scores. So like I said, each system is assigned a score from 0 to 4 based on their dysfunction. And the scale is 0 to 24, 0 being completely normal, and 24 I would assume being pretty much dead from sepsis, severe septic shock at that point. So that's everything in a nutshell as far as the SOFA score and the GCS. For the GCS, I do expect you to be able to calculate a GCS given a scenario. For the SOFA score, I just expect you to understand the severity of the patient's sepsis or septic shock given this situation and mortality rates associated with it. I don't expect you to calculate a SOFA score or anything like that. It's just more or less to add gravity to a scenario and understand where the clinical trajectory is going. Okay? I plan on doing these every week. I'd rather you guys kind of send me ideas of things you want me to discuss, go over, or elaborate on, and I'll make these videos and put them out there for everyone. If not, I'll pick not random, but little things that I think are important to really focus on for each week and what we're discussing and how they apply to you clinically, and also potentially to the ACCS examination. All right, thank you guys for watching, and I'll see you guys next week.